Okay, well, welcome. Good morning, everyone. Welcome to the St. Paul's campus in Harvard Square, both you who are with us in person and those joining us on the live stream. I am Deacon Tim O'Donnell, Executive Director of the Harvard Catholic Forum, which is based here in the St. Paul's community. We are honored and delighted to be hosting this event with the Guild of St. Luke, now for the second year in a row. As many of you know, the Guild is an organization of Catholic physicians here in the Archdiocese who meet several times each year to discuss issues of moral and ethical significance in healthcare, as we will be doing this morning. In a few moments, I will turn the podium over to Dr. John Baravecchio, President of the Guild, who will moderate the program and introduce the speakers. And let me say thank you, John, for bringing together this excellent panel to address such a critical topic. Allow me to say a quick word about the Harvard Catholic Forum, which offers lectures, non-credit courses, and other programs in which the Catholic intellectual and cultural tradition engages the academy, the professions, and the arts. Check us out at harvardcatholicforum.org to receive emails about our future programs, both in person and virtual. There are some brochures and program announcements next to the door as you leave as well. Here are some logistics about this morning's program. After Dr. Baravecchio's introduction, each of our two distinguished speakers will speak for 30 or 35 minutes. Immediately after that, we will move into Q&A, finishing around noon. We have lunch spread on the table there and invite you to stay, have something to eat, and continue the conversation. Note that the program will be continuous with no scheduled break. You are welcome at any time to use the men's and ladies' rooms, which are out in the door through here and immediately to the left. Just please avoid walking directly in front of the camera over here, which is doing the live stream. Today's program will be recorded and posted on the Harvard Catholic Forum YouTube channel. The recording can be accessed through the archive on the forum's website, harvardcatholicforum.org archive. There also will be a link to the recording in the news and events page at guildofstluke.org. So please let friends and colleagues who couldn't be with us today know that they can tune in to the recording later. About the Q&A. All of us, and especially the speakers, look forward to your questions, so please have them ready. The Q&A will be included in the live stream, but note that the Q&A section will be omitted from the recorded version. So questioners, your voice and question will not be on YouTube forever. In formulating questions, please make them brief and be sure that they are questions seeking responses from the panelists that will be of benefit to the whole audience. Also about the Q&A, for those of you on Zoom, unfortunately, we are not set up technically to take questions from the virtual audience today. There is just one thing I need to ask of you. Please help us and our co-sponsors by taking 2 minutes to fill out the survey about the program. Those of you in the Zoom audience will get a survey right after the program ends. For our in-person audience, there is a very brief paper survey. You should have received one along with a pencil when you came in. If not, there are more on the table by the door. And please, as you leave, whenever that is, after lunch or whatever, take a minute to fill it out and leave it in the basket by the door. And finally, I want to draw your attention to another basket by the door marked contributions. You can help defray the cost of this program by leaving either cash or a check made out to Guild of St. Luke in this basket as you leave. Thank you for your support. And now, please welcome Dr. Baravecchio to introduce the program.
Good morning, everybody. Dr. Paul Hruz is an academic pediatric endocrinologist and physician scientist in pediatrics and cellular biology and physiology at Washington University in St. Louis. He has over 25 years of clinical experience in caring for children with disorders of sexual development. He serves as a consultant to the U.S. Conference of Catholic Bishops and National Catholic Bioethics Center and has numerous publications. He's immediately here to my left. Dr. Greg Kolodziejczak, the furthest on the left, is a clinical psychologist in private practice here in Cambridge. He's been a consultant for the Catholic Schools of the Archdiocese of Boston, as well as teaching some classes at St. John's Seminary. Among other things, he has worked with the Office of Religious Education of the Archdiocese of Washington and multiple ministries dealing with marginalized populations while in religious life previously. Welcome our speakers.
Well, thank you very much for that introduction, and it really is my honor and privilege to be here with you this morning. Since this is a sponsored activity of your local Guild of the Catholic Medical Association, I just want to make sure that we offer everything that we're doing here to the greater honor and glory of God. We entrust everything that we are talking about here in this very difficult subject matter to our Lord, and we ask in a particular way for His blessings upon all of the people that are affected by this condition that we will be speaking about this morning. So I want to, before I get started, I'm obligated to just make the disclaimer that even though I'm going to talk to you about matters of science and best medical practice, that I'm not going to be representing my university or the Children's Hospital where I work at. So just to leave it at that. Now, before I get into the matter of science and looking at medical evidence designed to aid these individuals that have a sex disorders and gender identification, we do need to begin by acknowledging that these individuals are truly suffering. It's very well established that those that have this experience have a markedly elevated risk of depression, anxiety, eating disorders, substance abuse, and even things like homelessness, and been subject to physical and verbal abuse. They're literally crying out for help. So it is important, myself as a physician and a physician scientist and the medical profession as a whole, to be attentive to this need. The question that we need to ask is what is being offered to these individuals to help alleviate their suffering? And is it truly the best approach? Is it really fulfilling the goals of medicine to restore one to a state of health? And as we think about this, I'm going to begin very basic, and I think most of you that are involved in medicine will understand that much of what we do in medicine is based upon trying to do our best in understanding the disease process and developing therapies that are truly effective. In the realm of science, we begin often, and really always, I should say, with a premise. There are things that we come to the table with our understanding of the human person and the condition, and we use that premise to design or to formulate hypotheses that we will rigorously test to see whether they have benefit. And it's important to, at the outset, before I actually get into the whole question of the role of medicine, to acknowledge that in this area of gender dysphoria, that there are two competing premises. And we by premises, they're not experimentally testable, that we start with that. Historically, it was understood that individuals that had this condition had a primary influence, if not a determining factor, that was psychological. And that if one understands this condition of gender dysphoria in that way, the hypotheses that one's going to put forward are going to be to address those underlying psychological difficulties that they're having. Now, in the current culture, there is a competing hypothesis or premise that states that when this discordance occurs, that the mind is functioning well and the problem is actually with the body. Now, if one accepts that premise, then the hypothesis of intervening by aligning and manipulating the appearance of the body would actually make sense. Now, as we think about this, this is really what came about really a couple of decades ago, around at the turn of the century. And it really, I'm not going to go through the whole history, but there was this change that occurred that was not based on new scientific evidence. It was a change in an ideology, an understanding of what is going on in these individuals. And so by accepting that second premise, then the goal was to be able to engage in achieving the changing of the appearance of the body to conform to one's gender identification. Now, what's unique about this as well in the recent developments is that it was recognized that the physiologic changes that occur during puberty actually are very distressing to these individuals, and it was proposed by some Dutch clinicians that perhaps we could abort those changes by stopping normally timed puberty and then offering them the sex steroid hormones in that more native environment to increase the success in making those phenotypic changes, thinking that that would be more beneficial. In fact, the Dutch did an initial longitudinal study where they recruited 70 patients that were self-selected, excluding any individuals that had any underlying psychiatric diagnoses or difficulties, without a control group, okay, and then longitudinally followed them over time with what is now referred to as the Dutch model. Now, this study has many limitations and many, frankly, very significant difficulties in the way that they assessed gender dysphoria that leads to questions about its validity, even within the study itself, but certainly in what's going on today. One of the major limitations of the study is that they concluded that gender dysphoria was improved, but in doing so, they used a study methodology where they had a survey that was unique whether you were male or female. What they did is that one took the questionnaire for the males desiring to appear female at the beginning of the study, asking questions about things that would be unique to male physiology. And then after the intervention, they switched the scale. And so they now rated the males as females, and they concluded that there were benefit. By that study design alone, there's questions about the validity of that study. Now, there are many other weaknesses in that study, but we have to ask whether it's even applicable to our current population. These are individuals that had the prepubertal onset of sex disorder and gender identification, and again, they excluded many of the patients that had underlying psychiatric morbidity. So this is just a schematic of the paradigm of the Dutch model. This comes from a review article that recently came out, or a systematic review in the UK, but it outlines, I think, many of the components, and it begins with psychological assessment and intervention, and it continues in the diagram throughout the course of care. My colleague will speak more about elements of this. But the first medical intervention from a physician, myself as an endocrinologist, would be to give medicines to abort normally timed puberty, using medications that we'd been using for many years to treat central precocious puberty, and then transitioning them to sex-discordant steroid hormones, meaning giving estrogen to a male and testosterone to a female, and then in the next stage, offering surgical interventions. And the way that this has evolved over time is that the way it's practiced, and certainly here in the United States, is there's actually a dismissal or a deprioritization of the psychological interventions, looking at this as being optional, and many have even said that it's a barrier to getting the drugs that these patients are coming to the clinics seeking. So as we think about this paradigm here, it's become very difficult to even question this model when assertions are made saying that we have figured out the ideal way to care for these individuals. This approach is both safe and effective, and many of the medical organizations are supporting it formally in their clinical practice guidelines or statements that they make, not recognizing that it's only a very small subset of these societies that are actually making these pronouncements, and not critically evaluating the evidence that lies behind these recommendations. The most prominent organization is really the World Professional Association for Transgender Health, or WPATH, that has put out a series of what they call clinical or standards of care. They're in their 8th iteration right now. They're not really standards of care. By definition, that means that every physician would agree to it, and the controversy that we have really negates that. It's their own version of their guidelines. In my own professional organization, the Endocrine Society, they've had 2 iterations of their clinical practice guidelines. And it makes it very difficult to ask the fundamental questions that we would ask in all areas of medicine, not just gender dysphoria, if we're trying to really design and implement the most effective care for these individuals. Now, fortunately, in the Endocrine Society guidelines, they've actually looked at a rigorous way of the quality of evidence. Before I get into some of the challenges that we have in this area, I want to point out that much of what comes from these guidelines is based upon, quote, expert opinion, all right? And we pride ourselves in medicine that it's evidence-based. We like to say that we were doing evidence-based medicine. And that's very different than eminence-based medicine, okay? It's the experts saying we know what's going on. Now, there is a tension between these two, because if you seek to have every question answered, you would never do anything at all. So we sometimes need to act before we have a full answer of what's going on. But there's a proportionality that we do in all of medicine related to relative risk and benefit. We always do a risk-benefit analysis. So we look at a risk-benefit to the intervention itself, what the risks are associated with that, what is the risk of not intervening and using that, but also in that risk-benefit analysis, the higher the risk of your intervention demands a higher level of evidence before one proceeds. This is just basic medicine. This is not related to uniquely to gender dysphoria. And unfortunately, when we look at the data, we've not followed that model when we've been engaged in the care of people with gender dysphoria. And I'll explain to you as best I can in the time that I have why there are major questions and concerns about the evidence base that is being used to put forward this intervention. Again, there are a hierarchy of levels of evidence. And if you look at this pyramid here, at the very bottom is that case report, expert opinion type of evidence. Okay? We seek usually to go to higher levels of evidence that will work up to things like longitudinal studies and then randomized controlled trials, and then looking at meta-analyses of multiple trials to be able to determine whether any intervention is appropriate or not. Now, this is just a description of the grade system. One of the ways that clinical practice guidelines are routinely assessed for their reliability based upon scientific evidence. And this has been around for quite some time. And they usually rate these studies of evidence from very low to high quality evidence. What isn't recognized, for example, in the Endocrine Society guidelines, that nearly all of the recommendations that are made in the guidelines, originally in 2009 and revised in 2017, are based upon very low quality evidence. And by definition, that means that the true outcome is likely to be very different than one suspects that it's going to be, meaning that, and I'll go through the reasons why that is rated as low quality evidence and why it's very important. So what are the limitations in the studies that are currently out there? And I want to say very clearly that the vast majority of the papers that are published in the area of gender dysphoria have these major weaknesses. And by having a larger number of papers with the same weaknesses doesn't make it any better, okay? So many of the studies are done in very small sample sizes, and I won't get into the details of what we know and don't know about the etiology, but it's likely a multifactorial etiology in any one individual differing predisposing factors. so it leads to generalizability questions, but it also leads to problems. Many of the times the studies are done in an uncontrolled manner, or they use improperly designed controls. They're a very short duration. There's very often a large loss of patients during follow-up, which we have no idea exactly what's happening. They use methodologies, cross-sectional retrospective studies, that at best can show associations. They can't state a causal relationship between the intervention and the response. And because they're not controlled, you don't know if there is any benefit that one sees, whether it's related to the intervention or not, or some other factor that you're not looking at. And I'm going to point out a very obvious one there. And then we have to address this question of bias. Now, I would say that in all of science, bias exists. Our role is to be able to minimize biases, and when we ignore the biases that might be present, we're at our own peril. So if we say that we're not biased, we're already in danger. So what we try to do is acknowledge any particular biases and then try to work to minimize them by the way we design the trial. And this often works when you have people that have competing hypotheses in dialogue together to be able to mitigate that. Now, what are some of the biases? I can't go through all of them. And you'll see in many of the studies, there's a selection bias. And you don't have to be even a scientist to know that if you design a study where you recruit your study subjects from an online website that is geared toward a particular ideological perspective, and tell the prospective study subjects what the goal of the research is, basically what they're trying to prove. And this is a very real example. For example, the 2015 transgender survey recruited patients from an advocacy website saying, we're going to prove that people, that affirmative care is the way to go, and that people are evil if they don't provide this care. All right, so that leads to both demand bias. If you tell them what people will change their responses to conform to what they think they're supposed to say. There's recall biases. They don't see history necessarily accurate. And then the investigators themselves often have observational bias. Okay, so there's, for example, a confirmation bias. If the way that science is normally done is that one begins with the hypothesis and you look to disprove the null hypothesis. So you begin with a skeptical view of what's going on. Now, to engage in scientific experimentation where you have a predetermined conclusion and you look for data to support your conclusion is not the way science is normally done. And that is, again, very, very important as we think about this. Now, I'm not going to go through each of the studies here. This is just a summary of some of the major studies that have been published in this area that have been used to support the affirmative model of care. And I just want to point out that red in here is not good. Okay, these are studies that are problematic, and the first two on there are actually the first original cohort that I mentioned about the Dutch study, and then the follow-up paper there. They started with 70 subjects. In the follow-up paper, they were down to 55. One of the patients in the study actually died as a surgical complication, so again, necessary. And in those studies, you can see that the sample sizes, the lack of controls, and I want to point you out to the confounders at the very other side of the slide here. One of the major confounders in many of these studies is they don't control for psychological interventions, so that if one is receiving psychological support, that if you see a benefit, you cannot say from the study that it was the affirmative hormone intervention versus the psychological care that they received. So again, that's going to be very important to the second half of our talk here this morning. So as we go through, these studies here, it's not just me, saying this as I've read the literature over the last 2 decades, trying to understand what is going on here. There's actually been a number of systematic reviews. These are rigorous methodologies to look through the literature and be with defined criteria to be able to look at this evidence base. And they have all, the ones I have listed up here, these major systematic reviews have all made the same conclusion, that the evidence base supporting the affirmative model of care, particularly in the care of adolescents with sex-discordant gender identification, is incredibly weak and cannot be used to justify the intervention that is being put forward. There are many questions that have not been answered, and there's a need for higher quality evidence. So I'm going to transition now to just going into some of the specifics of the interventions themselves. And we're going to look at this through the lens of what we do know and what we don't know, using very obvious, would seem, understanding of the human body and the ramifications. Again, knowing that the evidence base is limited, but we're probably on more solid footing by looking at the risks or adverse effects of these interventions, and that's what I'm going to share with you. Now, let's be really basic, okay? We're talking about sex and the relationship of how one sees oneself related to their sexual identity, what we call gender identity nowadays. And we know from a biological perspective that this is inherently directed toward the process of reproduction. That's a biological fact. And we know that even though people claim that sex is along a continuum, there really are only two gonads that participate in that reproductive process, testes and ovaries. So looking at this as male or female, and that when you have a disorder of sexual development, one generally has an impairment or absence of that fertility that defines who we are as male and female. It's also important to know that people try to make it more complex in talking about sex in a way that we have a chromosomal sex and a hormonal sex and a phenotypic sex. Much of the sexual differentiation that leads to the differentiation of an individual in utero to have either testes or ovaries is controlled by very specific genetic information, very elegant, and we understand more and more about the developmental processes that lead to that sexual differentiation. But it's important to remember that these sexual differences are not confined to the sexual organs. They're actually present throughout the entire body based upon genetic factors. And one of the factors is epigenetics. We know that there are definitely different genes that are expressed in males versus females. There's a whole field of medicine known as sex-specific medicine, knowing that the disease susceptibility and response to medications differ as to whether one's male or female. So we have to acknowledge that. We also can look at these claims saying that one can be born in the wrong body. They may have a male brain and a female body or vice versa. It makes no sense at all if you understand the basics of physiology and these differences that occur. It's true that there are differences structurally and functionally between males and females. Much of that difference actually relates to different roles that males and females have, not only in conceiving new life, but in raising the offspring that come from that sexual encounter. So the segregated roles and the trade-off that one has in the body to be able to do this effectively. So there's a division of labor that occurs. These differences, though, are very broad and they overlap so that we can't determine the sex of an individual by looking at these factors. It's just not possible. In the same way that we know that there are stature differences between males and females. Males are 5 inches on average taller, and we can't determine the sex of an individual by measuring their height. It just is not possible. When we look at this, it's going to be important that when we talk about these hormonal interventions, that there are different responses, and that these sex steroid hormones themselves are going to have an influence in that. The brain is not fully developed until the early 20s, and we have a longstanding literature that shows that there are roles of the sex steroid hormones in mediating that developmental process there. So let's talk just very briefly about the claims that are made in the first step medical intervention in the affirmative model, that of pubertal blockade. Now, these are the claims that are often made, and I'm going to go through each of them and share with you why there are major questions and concerns about these claims. The first is that it's entirely safe and fully reversible. By entirely safe, they're drawing upon literature when we've studied the use of this intervention in treating central precocious puberty. But we know from other areas of medicine that it's problematic to take the treatment of one disease and apply it to another disease without rigorously testing this. It's not been rigorously tested in the way that it needs to in interrupting normally timed puberty. Fully reversible refers to when you withdraw the drugs. These are what are called GnRH agonists that shut down the signaling from the pituitary gland to the gonad. When you stop that medicine, that signaling process will resume. That's what they mean by reversible. But you have to keep in mind that the physical changes that occur during puberty, leading to sexual maturation, are accompanied by the psychosocial changes known as adolescence. And if you've disrupted a temporally dependent process, you cannot buy back time. So objectively, we cannot say that it's reversible. If you give the puberty blockers and then allow them to re-enter into puberty later, there's going to be a significant difference there. The claim that it'll alleviate the dysphoria is actually likely to be true. Okay, so that the distress that one experiences when their body is changing in a way that they don't want it to change, if you take away that change, it's going to alleviate that distress. But I have to state what we know in other areas of pediatrics, that this time of adolescence is inherently stressful, but it's a necessary part of development. The equivalent that maybe I could share with you is that if a child is distressed, that they have a math test next week, and you tell them that they don't have to take the test, their anxiety is going to be immediately relieved. But are you really helping them? Okay, so we have to ask whether that's a good thing. There's a claim that it says it allows a child more time to explore their gender identity. So it's kind of like a pause button and gives them more time to kind of reflect and decide whether they want to go forward with the later stages of intervention. However, the data speaks very differently about that. Okay, and I think in my next slide, I will show you some data on this, that virtually every person that gets put on puberty blockers will progress on to later stage or hormone intervention. Okay, so it's not really a pause button. It's actually pushing them down a particular path, and we can ask questions about why that might be. And then the claim that it's going to improve the cosmetic outcome. Again, it's easier not to have to reverse the pubertal changes that occur. That part is probably true, but the expense of doing that in changing the body and in altering the normal physiology. So these individuals, it's important to know, the vast majority of individuals that present with gender dysphoria prior to medical intervention have normally formed and functioning sexual organs. So we are actually inducing a state of iatrogenic disease by impairing their sexual function that may be irreversible. Okay, and that's summarized in the site here. I've given you one of the references, I think, that speaks to this question of going on to later stage interventions, the persistence question. For those that want to read more about it, several years ago I wrote a very, very extensive paper with my colleagues Larry Mayer and Paul McHugh that goes into details about all of those, and if you want to read that, it's freely available online. Now, in transitioning to talking about the concerns about the cross-sex hormones, the sex-discordant sex steroid hormones, we have to understand how these hormones work, okay? Hormones in general. Hormones work by binding to receptors within cells in the body, leading to translocation to the nucleus, and they turn on and off a variety of different genes. This is in every cell of nucleated cell of the body, not just in the primary sex organs. And it's very well known that there are sex-related differences that are even independent of steroid exposure. In fact, there are over 6,000 sex differentially expressed genes throughout the body. So to make the claim that giving estrogen to a male is going to be the same as giving estrogen to a female is, on the surface, objectively speaking, false, okay? And we know this, okay? We know this in many other areas of medicine. So we have to critically evaluate what that effect is, and does that risk, is that justified in relation to potential outcomes? I want to illustrate the point maybe a little bit more clearly for you, exactly what's going on in these individuals. I use the example of females that are being exposed to exogenous testosterone in relation to what we know in other conditions. Okay, and I'm showing you on this curve here in blue is the normal levels of testosterone in a female. In gray, I'm showing you a condition known as polycystic ovarian syndrome, which is a recognized disease where you have hyperandrogenism. And we seek, when we encounter this condition, to be able to lower androgen levels, not only because of the phenotypic changes, but recognizing that it puts an individual at much higher risk of metabolic and cardiovascular disease and other adverse effects. In the next slide I'm showing you here is what you would see in an endocrine-secreting tumor, and then showing you the levels that are achieved in the females that are being treated as part of the affirmative model. So even before we look at the data, we may have questions about whether this might be create some problems. Okay, we'll just leave it at that. So then let's look at the literature. Again, I don't have time to go through all the details, but giving sex-discordant steroid hormones to individuals, there's a growing literature base showing the adverse effects, and I'll just point out some categories. I'm going to start with probably the most significant, and that's a reduction in fertility, which can be infertility or outright sterility. All of the data would suggest that if you block normally timed puberty, you prevent the gonad from mature, and have that immature gonad exposed to the sex-discordant steroid hormones, the expectation is that that is going to lead to lifelong sterility. People will make claims that you can be fertile afterwards. All the reports are in people that were exposed to these hormones after gonadal maturation. That's not what's going on on the model. There's a risk with giving testosterone, polycythemia, increased red blood cell count leading to strokes, thromboembolic strokes, by some reports up to 5-fold increase in stroke, which can be cause to neurologic impairment and even death. There's a lot of literature conflicting, but about cardiovascular effects, metabolic changes, predisposition to diabetes, obesity, severe acne. This is actually not insignificant because these are individuals that are already bothered by their appearance, and this is very severe and can be very devastating to them. And unanswered questions about cancer risk. We know that, for example, giving estrogen to a male increases breast cancer risk. Much of it comes from lack of screening, but also the effects of the hormones themselves. So now, many that are offering this affirmative care will acknowledge these risks. They'll try to minimize the risks, but they at least acknowledge that they exist. And when they consent or attempt to consent to this form of intervention, they will share with them, for example, the risk of impaired fertility. And they'll even often try to have a discussion about how we might be able to fix or preserve or improve fertility that we've intentionally impaired. Okay, there's many of them at the age in the adolescent years that aren't looking for that advice, and they won't heed that. But they will accept this, saying that, well, we're going to prevent them from committing suicide. Now, this is one of the most concerning aspects of this, is when one actually looks at the way the data is put together, methodologic flaws, that any conclusions that have said that that rate has changed, it can't be supported. Now, since the studies have not been properly designed, we can only say about associations. And this is a study that came out, now this is not in children, this is in adults, looking 20, 30 years after this affirmative approach. And this is, the slide I'm showing you here is on all-cause mortality. If you look at the data in that Swedish cohort study, which doesn't have the recruitment bias because this is from medical records of every individual in that country, the ongoing rate of completed suicide remains 19-fold above the background population. That's after this intervention. Since it wasn't controlled, we can't say what it would have been without the intervention, but we can clearly say it didn't fix the problem. Okay, and it's not only the Swedish study, we've had other studies as well. This is the Dutch cohort as well, looking at, and here they break it out between males and females. And the curves here, they're comparing you from, whether you're male and whether you transition to have an appearance of a female, and you can see the all-cause mortality rate being vastly different. That's really the comparison that one would need to have. Many try to minimize this by saying you merely assume the risk of the other sex, for example, on cardiovascular effects, but the data actually doesn't say that. It says actually there's, and this is not even talking about suicide, this is all-cause mortality. So the claim that this is, and my colleague will speak, I hope, a little bit more about some of the psychological dimensions of what's going on here, but the claim that this is fixing the problem is not borne out by the data. And I think this has been consistently shown if one objectively looks at the data as it's being portrayed, and that even if it alleviates dysphoria, which is questionable, that it may not provide that long-lasting help. Now, fortunately, throughout the world, there's been a move to greater caution. In this slide, the number of countries that I can put on here continues to grow, where the medical establishment and the governments of these countries have said, let's put a pause on this. In Sweden and Finland and other countries, they said, well, if we're going to engage in this care, we need to do this in the setting of an experimental trial, because it's still experimental. Unfortunately, in the United States, the medical establishment has refused to acknowledge this growing recognition of the poor quality data and the less than satisfactory outcomes. In the United States, as you probably are aware, our federal government now has put a national pause on this. It's not been supported by most of the medical associations. It's been perceived as a political solution to this problem, or politically driven, not recognizing all of what I've already shared with you this morning. That this, just on the basis of objective looking at medical evidence, scientific evidence, that there are many concerns about what's going on. There are many questions about what we need to do moving forward. So in the last slide I have here, I'm just going to briefly tell you that what we need is better research. And what we need is not only better research, one of the glaring holes in everything that's been done so far is to rigorously test the alternative hypotheses, that this is a psychological issue and that the care that is being given on a psychological basis is what's the path to true and sustained health. And so how do we conduct those studies? There's many claims that are made that we can't do the research. There's something called equipoise, that you have to have uncertainty about the outcome to be able to engage in it. When you make the claim we've already solved the problem, they claim that it's unethical to engage in these controlled studies. And that can't be made based on what's going on. They also propose studies in a way that is not the way science is normally done. So by a controlled trial, we have to recognize that in the controlled trial, the control group doesn't mean no care. Okay, so that what you do is you look at your independent variable that you're going to be testing. Everything else remains the same. And when you present it in that way, the other claim that people will make is that you can't do the research because nobody would sign up for it. Well, if you're presenting it as, this is the valid approach, and then these crazy people want to do something else and you might be harmed by it, nobody's going to consent to that. But if you acknowledge what I've just shared with you to the prospective study subject, that we don't know what we're doing, there may be alternatives that actually alleviate your suffering in the proper way with the safeguards of an IRB board, we have a path forward. And I won't say much more right now. Maybe in the questions if we can go into more detail about that. I want to leave time for my colleague to talk about the psychological dimensions. But I do want to say that that just in summary, that much of what's going on in the area of the affirmative model of gender care is based on very low quality evidence. We know very little about what we're doing. We have evidence that suggests that we're not doing the help that we claim that we're giving. And that in the same time, as we're working toward these solutions, we need to maintain our attention to the suffering patient and really, acknowledge the suffering that they have, enforce their dignity as human persons, and that's really what we need to do in all of medicine. It's not a Catholic thing, it's a medicine thing, it's a human thing. And so with that, I'm going to thank you for your attention and look forward to the next part of our presentation this morning. Thank you.
Paul, thank you so much, and it's a real pleasure and a privilege for me to be here with you today. And I begin with this photograph because exploratory therapy, and that's what I'm going to be talking about, if we don't just rush into hormones and medical treatments, but we actually do therapy and try to explore what's going on, we call that exploratory therapy. And it is an unknown path that we follow and see where it leads without a known outcome. And basically, I'm going to be giving a little bit of an overview, some basic principles of exploratory therapy, and then I'm going to be talking about 3 specific developmental frameworks that I think inform some of the ways that we can look at this. I'm not sure I'm going to get through all 3, but we'll see what we can do. I'm going to start out with this statement of belief from an organization called Therapy First, whose basic premise is we ought to lead with therapy. And they write, individuals who are exploring gender identity or struggling with their biological sex should have access to therapists who will provide thoughtful, developmentally appropriate care and tend to legitimate mental health concerns without pushing an ideological or political agenda. Now, to me, that's a no-brainer. That's common sense. But it's controversial. Various people, including this person on his website, says gender exploratory therapy has a new name. It is still dangerous. It is conversion therapy. And conversion therapy is the third rail. these days, that if I go into this with, I have an objective that I'm going to fix you or cure you, that is a third rail. And so we need to be open-minded and just explore and see where that leads without any preconceived notions. Now, although Dr. Hruz has noted some maybe biases of the World Professional Association of Transgender Health, their current statement of care in the chapter on adolescence notes, we recommend healthcare professionals working with gender-diverse adolescents undertake a comprehensive biopsychosocial assessment of adolescents who present with gender identity-related concerns and who seek medical, surgical, transition-related care, and that this be accomplished in a collaborative and supportive manner. Now, again, to me, that's common sense. But as this was pointed out in a New York Times Magazine article, that the lead authors of that chapter, Scott Leibowitz and Anna Lou DeVries, who have long histories in the transgender world and researching and working and advocating for transgender patients, were considered traitors and pariahs in their own community. Why? Because they advocated a comprehensive biopsychosocial assessment rather than merely fast-tracking people into hormones and surgery. So it is a very divisive field. Along these lines, I would note that some of the early research in the Dutch clinics in Utrecht and Amsterdam noted that it is important to keep in mind that many applicants are not good candidates for sexual reassignment and probably never will be good candidates. Applicants vary greatly in family background, education, psychopathology, motivation to explore gender issues, and outcome. Although psychopathology may be the result, rather than the underlying problem, of what was then called gender identity disorder, sexual reassignment may also be sought as a solution to non-gender problems. And that's what one of the things we're exploring in exploratory therapy. Also noted they also have studies where they had certain individuals that they decided, no, should not go forward and were the non-treatment group, and they ended up improving and coming to other ways of resolving their gender dysphoric issues. So when we think about exploratory therapy, what is it we're exploring? I would argue that the primary thing we're exploring is the whole person. Only secondarily is gender identity. That gender identity is within the context of the whole person, and that is where we need to have our main focus. And why are we exploring? For me, 3 reasons. 1, to assist the person's growth in self-understanding, self-awareness. 2nd, to assist the person in making free and informed decisions regarding their future, including any decisions they're going to be making on gender. I respect their autonomy on that. 3rd, assist the person in navigating or addressing any difficulties, needs, or concerns they might have, including about comorbidities, any struggles they're having with depression or anxiety or OCD or whatever it might be. Now, why is all that important? A few years back, I had a patient. I'll leave all this as vaguely as I could. The patient had a prior therapy of several years with a very good therapist. He was well known, very qualified. That therapist moved out of state, and so the patient was looking for a new therapist, and the patient's psychiatrist contacted me because the psychiatrist knew I was willing to work with people who had hospitalizations. And so in the first session, I learned that the patient described, self-identifies as non-binary. Okay. Took a life history, very clear history of fairly serious trauma, particularly in romantic relationships, and also some family of origin trauma as well. Now, I didn't want to reinvent the wheel and go over stuff that had already been done in prior therapy, so I said, you know, I'm curious, how was this talked about in your prior therapy? Quote, it never came up. Wow. Prior therapist was so narrowly focused on gender issues that they didn't even address a history of fairly serious trauma. Exploratory therapy does not fall into that trap. There's something called diagnostic overshadowing, where people will focus so much on gender issues it overshadows everything else and ignores them. And that's a real problem, not only for this person, it's a problem because we are in a mental health crisis. Suicide right now is the third leading cause of death for young people. And as this Australian author points out, the increase of children presenting to health services with gender dysphoria is part of a broader pattern, an increase of young people presenting to health services with distress and a range of psychiatric symptoms: anxiety, depression, suicidal ideation, self-harm, suicide attempts, autism, the list goes on, often comorbid with one another. It's important to take those seriously, to look at the whole person and understand how we can be of assistance to them. Now, we've talked about suicide, and Dr. Hruz mentioned suicide as well. Suicide is especially high in kids who identify as trans or gender diverse, and that is a real tragedy. And a lot of the research on that comes from a study of it was a questionnaire, over 8,000 people responded to it. It was published in 2011 under the title Injustice at Every Turn. And one of the questions in the survey, have you ever attempted suicide? 41% of respondents answered yes. You will often hear that statistic. And that is a horrible thing, and it's a real tragedy. What I have never heard discussed or articulated is how that 41% breaks out among age groups. The highest rates of suicide in that study were reported among those in the younger age groups. Between 18 and 44, there was a 45% attempted suicide rate. For people over 65, it was only a 16% suicide rate. And that is inverse to the general population, which shows a higher incidence of attempts among older Americans than youth. Now, why is that important? Well, the high suicide rates are normally attributed to social marginalization, and that certainly is a factor. But people who are 68 years old, let's say, and identify as transgender had a lot higher social marginalization 20, 30, 40, 50 years ago than young people do now. And they've also had a lot more years in order to attempt suicide, and yet they have a dramatically lower suicide rate. In other words, something else is going on that we need to understand, and if we ignore that, I would say that's malpractice. So in terms of how do we do that exploratory therapy, I would say some basic principles, which I think for all of us would be obvious. Be respectful, be empathic, be curious and open-minded, treat the whole person, be knowledgeable and precise, foster reflection. I'm not going to say a lot about these because I think they're so obvious, but I will say that I would like to think that respect is taken for granted, but it's not. And I think it is true that a lot of people who present differently, including around gender, they are harassed, bullied, treated badly, according to this study, even sometimes in medical offices. Now, I don't know if that's the doctors or other people in the waiting room. I have no idea. I don't know what the details are. But the reality is they are often not treated with respect, and that is tragic and reprehensible. An excellent book, Learning the Virtues by Romano Guardini, lists one of the virtues that lead you to God as courtesy. I was glad to see that. Courtesy ought to pervade what we do. And sadly, he makes the observation that today courtesy is disintegrating everywhere. He wrote that in 1967. I suspect he would be appalled today. So to be courteous as a baseline, but that's in some ways even a low bar. I would say in dealing with patients, we should foster an I-thou relationship with them and treat them with a profound level of respect, knowing that Christ resides inside of them. I am steeped in psychoanalysis. Analysis is an interesting word. It's a great word. It's an important word. However, nobody wants to feel analyzed, like they're being dissected like a bug under a microscope. People want to feel understood. And so in the way we work with other people, especially patients, we want to communicate with them in a way that they feel understood, not analyzed. Rudolf Allers, who was a psychiatrist and a Thomistic philosophy professor and was a mentor to Viktor Frankl, wrote in a great book, 1940, published by Roman Catholic Press. The book has a nihil obstat and an imprimatur. He writes, understanding means standing under another, that is, bearing his burden and taking his place, sharing, therefore, his point of view. So to imaginatively enter into the mind and heart of the other person, which is essentially what we mean by empathy. To think and feel our way into the experience of the other person. Dick Geist, the self-psychologist, writes, the most fruitful way for one person to understand another is by empathically immersing oneself in another's subjective world. And certainly as a psychotherapist, I need to do that with my patients. But I think empathy is a fundamental life skill in all walks of life. And if I'm going to especially work with an adolescent who will sometimes be kind of guarded and leery and all of that, I need to be empathic and respectful. I need to take them and their ideas very, very seriously and do my best to both enter into their mind and heart and respond to them in a way where they feel heard and understood, or as we sometimes say today, they feel felt. To be curious. Our minds are wired in a way where we very quickly categorize things as true or false, right or wrong, good or bad, beautiful or ugly, valuable or worthless. And sometimes that's appropriate, but quite often not. And can I step back from that and keep an open mind and heart and be curious so I can more deeply penetrate into the issue or the person's mind and heart to really understand what might be going on here? And by doing so, can I also foster that stance, that framework, that mindset in the other person so that they cannot immediately jump to a conclusion, but be curious about their own experience? In terms of identity formation, one of the people who's written about this was a psychologist, James Marcia, who says there are kind of 4 identity statuses, especially in adolescence. Identity diffusion, where I've never really even thought about identity. I've just kind of, I am who I am, whatever. I've never really thought about it. Foreclosure, where I'm committed to identity without having genuinely thought about it and worked through it. Moratorium, where I'm kind of searching and thinking without committing to any particular identity while doing so. And then identity achievement, where I've done that, I've thought about it, and I have kind of committed to a particular identity. What we don't want is premature foreclosure. And so to help the person stay genuinely curious and open about what might be going on, how to make sense and meaning of their own experience in an open and curious way is part of what we try to do in exploratory therapy. I want to treat the whole person, not as a bundle of symptoms or whatever, but as a human being. And I think particularly with adolescents who might come into therapy a little, not always the most open in the world, I think this is particularly important. I had one patient who had very little to say, so at some point I said, "You're very good at word economy." And the person kind of chuckled about that and said, "Well, yeah, I don't talk a lot about, unless it's stuff I'm really interested in." "Oh, what are you really interested in?" And they talked, said a couple things. I said, "Oh, well, let's talk about it. I'd really like to learn more about that." And gradually formed a deeper bond, and then the therapy kind of deepened from there. But to find anything that will help find a way into the mind and heart of the person is helpful. Be knowledgeable and precise, no-brainer. Foster reflection. What I mean by that is to help the person to reflect deeply and rigorously on the full range of human experience. Where we all get into trouble is when either I don't really reflect deeply or I reflect only on a very narrow range of experience and ignore the rest. So a lot of what I will do at times is simply help the person to really reflect deeply on a broad range of experience, trusting that that will lead the person where they need to go. Okay, I'm going to shift now to developmental frameworks. And these are simply ways of understanding human development that I think help to inform the way we look at life, some of the things we can look for, some of the questions that we can ask. Now, these frameworks do not carve nature at her joints, so I don't want to use them as a Procrustean bed into which to force fit the patients. I think psychology has a long history of doing that. You know, I develop a theory and then I'm going to see everything through that lens and force the patient into it. I want to wear these theories lightly in ways that maybe inform me, that help me make sense of things, but always with a certain flexibility to see what fits and what really doesn't. Okay, so the first theory is attachment theory, and maybe many of you are familiar with attachment theory, I'm not sure. It was initially developed by British psychoanalyst John Bowlby and later furthered by American psychologist Mary Ainsworth and many others. It is the dominant and most empirically validated way of understanding human social emotional development today. An attachment in the psychological world is an affectional bond. It is pretty well universal across cultures. If there are cultures where it's not important, I'm not aware of them. And what we are interested in attachment theory is what is the quality or the style of that bond. There's two basic types, secure and insecure. We can probably guess by those names that secure is the preferred. And the rule of thumb for a long time was that about 60% of kids have a secure attachment. It's now less than that, probably 50% or lower. And there are three types of insecure attachment. Anxious, also called ambivalent, also called resistant. Those all mean the same thing. Avoidant and disorganized. With adults, we use slightly different terminology, but it's really a parallel meaning. Now, what we do know, what there's a lot of evidence to say, is that insecure attachments are increasing. In this study covering, basically it's a meta-analysis covering 23 years and over 25,000 college students, they found that there was a 15% decrease in secure attachment, along with a 56% spike in dismissive or avoidant attachment, and a nearly 18% increase in the fearful or disorganized style. The two types associated with a lack of trust and self-isolation. Okay, that is part of the growing mental health crisis that we're facing. Is this relevant to gender dysphoria? Yes. In this Australian study, they noted that while children from the non-clinical group, i.e. the control group, healthy, normal kids, mostly classified into the normative attachment strategies, the less serious ones, both secure and the less serious insecure, children with gender dysphoria were mostly classified into the at-risk attachment strategies. Children with gender dysphoria were also found to have high rates of unresolved loss, trauma, and high rates of the depression modifier. Okay, again, if we ignore that because we're so focused on gender, we're doing these persons a profound disservice. Now, we do want to recognize that the attachment issues were not, were not specific in terms of highlighting what's going on with the gender, but they were indistinguishable from the children with mixed psychiatric profiles. So, in other words, the attachment issues are part of the larger mental health crisis, which is all the more reason to understand the whole person. Now, I am always, when dealing with patients, thinking, what is the attachment style or attachment status of this person? But it's not just to put a label on them and put them in a category. It's also to understand how did that develop and what is the emotional tone of their family. What is it that creates in the family a good affectional bond, a secure attachment? It's a number of things, but fundamentally at its root is empathic attunement, the ability of the parents to empathically tune in to what's going on inside the mind and heart of the child, and then to respond in a way that the child feels like their inner life is understood and is connected. And so I'm trying to understand what was the emotional life, the emotional tone of the family, and how has that affected this person's development. Now, as the child develops in these attachment relationships, they are also developing understandings of, or we could say, internal mental representations of who they are, of who other people are, of how relationships work, and so on. These internal mental representations go by a number of names: schema, internal working models is the formal phrase in attachment theory, unconscious organizing principles, mental models. I generally use the phrase mental models. Mental models are a way of organizing experience about everything, but especially about who I am, who other people are, how relationships work, how life works. Dan Siegel, a psychiatrist at UCLA, writes, and by the way, these become the lens through which I now see life. And these lenses are outside our conscious awareness and bias our perceptions without our having conscious knowledge of their existence. They are built from past experience, are activated in specific ways, and function quickly to shape our view of reality, our beliefs and attitudes, and the way we will engage with the world around us. So always on my mind is, what are the mental models of this person here with me? Mental models of self, of others, of how relationships work, of life. A mental model of what does it mean to be a male? What does it mean to be a female? Of romance, of sex. If I'm a 10-year-old girl and I have some awareness of the pornography that's out there and the way it intrinsically treats women as sexual objects to be exploited for men's gratification, and often is intermingled with violence and degradation, you can understand why I might think, that's not very appealing. I don't really want to know. I don't know if I really want to develop in that direction. And so the mental models, which are overwhelmingly unconscious, are very relevant to issues of everything in life, including gender. It's also relevant to know that they do exist in an unconscious way. Human long-term memory has two basic types, explicit and implicit. Explicit memory is things like you remember that, the capital of California is Sacramento. You remember what you did yesterday. Implicit memory is other stuff that you remember, like you remember how to walk, but that's a very different form of memory. Okay, that's a form of implicit memory. Mental models exist overwhelmingly in implicit memory, and so they are unconscious by their very nature. Not because they're repressed in some Freudian sense, but by the very nature of them, they are unconscious. And hence, what is the unconscious? I thought this author in Scientific American said it very well. The characteristics of the unconscious and associated processes of brain functioning are very different than Freud thought. Rather than being a cauldron of untamed passions and destructive wishes, I propose that the unconscious is a cohesive, continually active mental structure that takes note of life's experiences and reacts according to its own scheme of interpretation. Part of what we do in therapy, including exploratory therapy, is try to come to an understanding of what is the scheme of interpretation. What are the mental models that are part of that? So that they don't operate in a hidden way, but I'm aware of it and therefore have more ability to manage it. Self-psychology. Self-psychology was developed by this guy, Heinz Kohut, a neurologist and psychiatrist originally from Austria. And as the name implies, self-psychology is focused on this thing called the self. Self is one of those words that it's important, but it's hard to define. It's kind of like intelligence in that way. The definitions I like are the psychological structure that organizes and gives meaning to human experience, and enduring capacities. The capacity to regulate my emotions, to relate to others, to exercise self-agency, to regulate self-esteem, to have a sense of continuity in space and time. All of those are developmental achievements. Babies are not born with that. They develop it, and they develop it in the context of family and relationships. Ernie Wolf, psychiatrist. The emergence of the self requires more than the inborn tendency to organize experience. Also required is the presence of others, technically designated as objects, kind of an unfortunate word, but who provide certain types of experience that will evoke the emergence and maintenance of the self. And those objects that do serve the growth and maintenance of the self, we technically call self-objects. And what are the experiences that evoke the emergence and maintenance of the self? Basically three: mirroring, idealization, and twinship. What do we mean by these? Mirroring. Anybody know how penguins feed their young? Yes. The baby penguin does not have the digestive machinery, if you will, to digest a raw fish. So the adult eats the fish, partially digests it, and then regurgitates it into the mouth of the chick. And the baby penguin can now metabolize that partially digested food and make it part of his or her bodily structure. We do the same thing with our kids' emotional lives. Infants and children do not have the ability to metabolize their own emotional experience. So we, the parent, take that in, process it, and represent it to the child in the form of mirroring in a way that the child can now take in, metabolize, and make part of his or her psychological structure. Parents do that all the time. Even something as simple as, oh my goodness, look at you, you're so excited about that. I'm tuning into what I think is going on inside the child's mind and heart, and I'm mirroring that in my tone of voice, in my facial expression, in my body language. And that is an essential step for the infant to be able to take that in and integrate it into his or her life. As time goes on, it becomes more and more verbal, but in the early years, it's entirely tone of voice, facial expression, body language, nonverbal. Now, in self-psychology, we're focusing on one particular aspect of mirroring, which is the child's desire for significance, for competence, for mattering, for greatness, if you will. Think of a little 5-year-old jumping off the couch and saying, look at me, I can fly. Okay, that needs to be mirrored in a way where the kid can possess a sense that, yes, you matter. There's something really good about you. And this starts very early in life. Coe said that the most important interaction between a mother and an infant is, quote, the gleam in the mother's eyes. That if I, the infant, am looking into mommy's eyes and they are on fire with delight at a completely pre-verbal, unconscious level, the message is, I delight in you, you're delightful. And that is a deposit of gold in the developing self-structure of the infant. Unfortunately, there's a lot of things today that can kind of get in the way of that. Furthermore, that kind of mirroring and affirmation is very different from gratuitous and indiscriminate praise, which is often what we have today. So if we think of mirroring and the way mirroring matures over time, we can think of a mirroring line of development, where as an infant, we have this kind of infantile, or we use the word archaic, desire to be the object of another's adoring gaze. But gradually that matures. So yeah, I want to be recognized and valued for who I am, but my need for mirroring has become internalized in my self-structure in the form of stable self-esteem and realistic ambition. And that now is a part of who I am, so I don't have to always go around being the object of others' adoring gaze. Idealization. Kids love to sit on your shoulders. They feel 8 feet tall. They can touch the ceiling. They can see forever, right? They do the same thing with that psychologically. Okay, my dad is my hero. You know, I'm connected, the child is connected to an idealized adult and draws upon that person's size, strength, intelligence, calmness to kind of prop up his self-structure, and he gradually internalizes that until it's a part of who he is. And so in idealizing, there is also a line of development from, as an infant, I need archaic merger. I just want to bury myself in mommy or daddy's lap if I'm distressed, and they calm me down. To gradually, yes, I need role models and mentors, but the idealization that I had located in the parent, I have now brought into myself in the form of values and ideals in which I'm emotionally invested. So they have motivational power, and also the ability to regulate my own emotions. Now, I don't have time to develop this thought, but I'm going to suggest that there is a crisis in idealization today. Anna Ornstein was a great self-psychologist. Well, she still is. She's in hospice care right now. She's in her mid-90s. But she was a Holocaust survivor, and she wrote a great article in 1999 where she basically makes the argument that as horrible as things are for children who are abused or neglected and all of that, which is terrible, or they're in the foster care system and they're bounced around from home to home, she is seeing the same types of symptoms in kids with very stable families whose parents bend over backwards to protect them from any sort of frustration, and who, in an attempt not to thwart the development of their children's independence and autonomy, seek their opinion and approval in relation to every detail of the family's life. The children are offered a wide variety of opinions related to food and bedtime, regardless of their age and ability to make such decisions. As she hopes to indicate, this particular parental behavior interferes with the process of idealization, resulting in a clinical picture that is not too different from those created by emotional neglect. Now, I would argue that there's also a crisis of idealization in the culture at large, in institutions. In fact, we no longer have heroes, we have celebrities, the list goes on. And so people crave idealization. Or, as Jungian psychoanalyst Paula Young-Eisendrath wrote, too many modern parents have innocently made the mistake of idealizing their children instead of truly loving them in ways that would allow the children to idealize the parents. Finally, twinship. I ran across this really heartwarming video on YouTube. Little kid Blake, whatever he is, 4 years old or so, shaving next to daddy. Mommy's filming. He's got his little SpongeBob mirror. And the first thing out of his mouth is, just like dad. And that sense of connection of I'm just like, that's what we call twinship. Heinz Kohut described the self-sustenance that a little girl might get from silently working in the kitchen next to her grandmother, that the little boy might get from shaving next to his daddy, or from working with daddy's tools in the basement. And that actually feeds and nurtures his developing sense of self. Now, we can look at this picture and we instantly know this is really healthy, right? That is really good for that little girl's development. Now, partly that's twinship, partly she's able to idealize her mother, mom knows how to do this, partly there's mirroring going on, so it's some combination of all three, but twinship is a really big part of it. When these activities don't happen, those needs for belonging are vitiated when a parent is unable to include the child in his world. Much like E.T. of movie fame, the child then feels like an alien from another planet, unwelcome, alone, and unable to share in the traditions of the culture. So in twinship, you also have a line of development from this craving for essential alikeness to a recognition that I'm similar and also different. I'm a human among humans, and I have a sense of shared humanity. So if all of this goes well, the person's self-structure develops in a mature, integrated, cohesive way. But if there are shortages or deprivations or distortions in these lines of development, you have a kind of a craving for those self-objects that can provide those functions. If the child does not acquire the needed internal structure, his psyche remains fixated on an archaic self-object, and the personality is throughout life dependent on certain objects in what seems to be an intense form of object hunger. And so the adolescent or the adult is craving kind of an archaic form of twinship, of mirroring, of idealization. It's one of the things that feeds cults. Okay, I need to idealize someone. I need to be just like everybody else, and so on and so forth. I would argue that these kind of craving, archaic needs are a big factor in the culture today. And so when I'm working with patients, I'm always thinking of what were their experiences of mirroring, idealization, and twinship? And what are their needs right now? And how does that play into whatever's going on in their mental health landscape? Is this relevant to gender? Yes. And the word gender there is in the original. It's in parentheses, but I didn't add it. Gendered individuality is strengthened through deeply experienced self-object connections. But unfortunately, for a wide variety of reasons, that process doesn't work particularly well in our culture today. And what I would argue is that leaves children open to a wide range of influences, including social influence. Anybody know who these people are? Jan Zimmerman, who has 2.2 million YouTube followers, and Evie Meg has 16 million TikTok followers. And they both have Tourette's. And they make videos of them having tics. And what happened was this results in a kind of a lot of people coming into doctors with tic-like behaviors, that they watch these videos and suddenly now I have Tourette's as well. And so in this one paper, they note over the last years, new onset tic-like behaviors have created a lot of interest worldwide. Of late, we and others have noted a marked increase of children and adolescents and young adults presenting with tic-like behaviors. When specifically asked, many of these patients reported that the tic-like behaviors commenced after the consumption of videos on platforms such as TikTok or YouTube showing persons allegedly having Tourette syndrome. Another study looked at 28 different TikTok video creators with Tourette's, and it looked at 2 days in March of 2021, and in those 2 days, the total viewing of the videos was 331 million. Wow. Now, it's not just Tourette syndrome. I mean, on TikTok, you can find things like, or, you know, these may be passé now, the cinnamon challenge, the Tide Pod challenge, the fire challenge. You pour a flammable liquid and set yourself on fire. The sunburn art, things that are just not really good. The stand in a circle and throw something up in the air while you're bent over. Okay, if you're doing that with tennis balls, okay. Doing it with a chair, not a great idea. Okay, now we human beings are imitative creatures, but I'm going to suggest that there's things going on in culture and in family life and in adolescent development that leaves people more predisposed to those influences today than before. Okay, another example, you know, eating disorders. Within a peer group, nothing is more contagious than a behavioral example from a popular and influential friend. Eating disorder behaviors can begin within these adolescent peer networks where friends routinely congratulate one another on weight loss or demanding physical exercise routines. Young people actively and competitively pursue crafted thin bodies which bestow unprecedented levels of symbolic capital in contemporary peer groups. Am I saying that someone who has gender dysphoria has an eating disorder? No. It's simply an example of the power of social influence. And as Erica Anderson, herself a trans woman and a longtime therapist and the former president of the U.S. Professional Association of Transgender Health, points out, how is it possible that gender identity formation constitutes the only area of development in which in adolescence that is immune from peer influence? And she's very concerned about how this has taken off and become so prominent and that we're not really exploring these things. And so she's a big advocate of exploratory therapy, and as a result, she's now considered a pariah in the trans community. So, internal family systems, we're out of time. I'm not going to get to that. It's another interesting framework that I think has a lot to offer, but I'll leave it at that.
Okay, well, thank you to both of our speakers.
For general knowledge, there's upcoming events for St. Luke's Guild. It includes the Archdiocese will have a Jubilee for healthcare workers on April 5th, 9 o'clock Mass at the Lazarus Center Healing Shrine in Wakefield. You know, it's going to be not just for physicians, but for healthcare workers. It's not a big place, so it seats about 400 people. And then we have I think the last Saturday in August, we have the St. Luke's Guild has a cookout here, and then we have a white mass with Archbishop Henning on October 4th, and we have a few other things in the pipeline. Maybe we could say the Angelus. The angel of the Lord declared unto Mary, Hail Mary, full of grace, the Lord is with thee. Blessed art thou among women, and blessed is the fruit of thy womb, Jesus. Holy Mary, Mother of God, pray for us sinners, now and at the hour of our death. Behold the handmaid of the Lord. Be it done to me according to thy word. Hail Mary, full of grace, the Lord is with thee. Blessed art thou among women, and blessed is the fruit of thy womb, Jesus. And the Word was made flesh. Hail Mary, full of grace, the Lord is with thee. Blessed art thou among women, and blessed is the fruit of thy womb, Jesus. Holy Mary, Mother of God, pray for us sinners, now and at the hour of our death. Pray for us, O Holy Mother of God. Let us pray. Pour forth, we beseech thee, O Lord, thy grace into our hearts, that we, to whom the incarnation of Christ thy Son was made known by the message of an angel, may by his passion and cross be brought to the glory of his resurrection, through the same Christ our Lord. Amen. And I want to thank the Harvard Catholic Forum for partnering with us in this. Thank you all. Lunch is served.